A warm welcome from Surendra Dental College and Research Institute, Sri Ganganagar. We have already discussed in the previous lectures the vital pulp therapy for primary teeth that included direct pulp capping, indirect pulp capping, and pulpotomy. And from this lecture onwards, we'll be starting with non-vital pulpectomy for primary teeth. Pulpectomy has been defined by Finn as the removal of all the pulp tissue from tooth, including both coronal as well as the root portions. Mathewson defined pulpectomy as complete removal of necrotic pulp tissue from the root canals of primary teeth and filling them with an inert resorbable material so as to maintain the tooth in the dental arch. And Ingle in 2002 defined pulpectomy as a non-vital technique involving the complete extirpation of irreversibly inflamed and or necrotic pulp followed by canal obturation with a resorbable medicament in the primary teeth. AAPD, that is American Academy of Pediatric Dentistry, in 2009 stated the objectives of pulpotomy as: following the treatment, the infectious process should resolve. There should be a radiographic evidence of successful filling without gross under or overfilling of the obturating material. The treatment should permit resorption of the primary root structures and the filling materials so as to permit the permanent succedaneous teeth to erupt uneventfully. There should not be any radiographic evidence of further breakdown of the supporting tissues. The treatment should alleviate and prevent further sensitivity, pain, or swelling, and there should not be any evidence of internal or external root resorption. Indications of pulpotomy are basically all those indications when the tooth is restorable, but the infection has already crossed beyond the confines of the vital pulp therapy. So the first indication of pulpectomy is in the teeth which have poor chance of vital pulp treatment success. When the teeth are of strategic importance with respect to space maintainers, there's absence of severe root resorption, that is at least 2/3 of the root length still remains, absence of any surrounding bone loss from infection, pulpless primary teeth without any permanent successor, pulpless primary teeth with sinus tracts, pulpless primary teeth in hemophiliacs. When there is pus at the exposure site or the pulp chamber, this is often the case when we already start the case for pulpotomy and then we realize that at the site of exposure or in the corner pulp there is pus or serous exudate. There is extensive furcation pathology or pulpless primary molars supporting an orthodontic appliance. The contraindications are first and foremost is non-restorable crowns as seen in this picture. Periradicular involvement extending up to the permanent tooth bud, which can lead to consequences or other sequelae in permanence. Pathological resorption of at least 1/3 of the root with a fistulous sinus tract. Excessive internal resorption. Extensive pulp floor opening into the bifurcation. Systemic disorders such as congenital or rheumatic heart disease, hepatitis, leukemia, or long-term corticosteroid therapy or immunocompromise, because these things can lead to a reinfection and thus life-threatening. Primary teeth which have underlying dentigerous follicular cysts. Coming to the technique of pulpotomy, basically there are two types of techniques. One is the single sitting, another is the multiple visit. The single sitting pulpectomy has been indicated in vital teeth where hemorrhage from the amputated radicular stumps is dark red, slowly oozing and is uncontrollable. The procedure remains the same, that is the conventional steps. The remaining caries should be removed, access opening, removal of the coronal pulp with the spoon excavator followed by the removal of the radicular pulp by files, then working length determination followed by irrigation and finally obturation. We will be discussing all these steps in detail later on. After the obturation, the post-endodontic restoration is also done. Multiple visit pulpectomy is indicated in non-vital primary teeth. The case selection is very important because if the case selection is improper, a single sitting pulpectomy can be an unsuccessful procedure. So, if there is an abscess, a chronic sinus tract, or there is a necrotic pulp with periapical involvement, and radiographically there is an indication of periapical abscess, then all these form the indication of multi-visit pulpectomy. The technique is again similar. If the tooth is mobile, it has a swelling or fistula, then only light instrumentation is done on the first sitting just to establish the drainage, and a dressing can be given with formocrosol. When the signs and symptoms subside after 2 to 3 days, then complete instrumentation is done. This can be followed by a dressing with calcium hydroxide so as to elevate the signs and symptoms, and after 7 to 10 days the canals are obturated. Now coming to the detailed procedure of pulpectomy. The first procedure of pulpectomy is the access cavity, followed by working length determination, preparation of the root canals, and finally obturation. We will be discussing the first steps here. The access cavity preparation is defined as the part of the cavity from the occlusal table to the canal orifice, and the objectives are to achieve a straight line access to the apical foramen or to the internal curvature of the root, and also to locate all the canal orifices, conserving the maximum amount of sound tooth structure. In primary teeth, the access opening is similar to permanent. However, there are certain things to remember so as to maximize the access feature. There is difference in the length crown, so therefore the chamber is reached earlier as compared to the permanent. The bulbous shape of the crowns, the very thin dentinal walls of the pulpal floors and roots prevent the routine step back so that we conserve the maximum amount of tooth structure. Otherwise, this might lead to a lateral perforation. The walls may require more flaring to facilitate the access to the canal as they are tortuous. In the primary anterior teeth, they are similar to the permanents. However, the palatal access is the conventional. In the primary, it could be labial also, depending upon where the sound tooth structure is more. For example, if there is anterior tooth with a gross destruction of the labial aspect, and in this case, the access can be established even from the labial aspect. The posteriors, it is the similar, that is in the maxillary molars. It is mainly in the mesial part of the crown. There are usually 3 canals: mesobuccal, distobuccal, and palatal. However, variation can be there. A 4th canal, that is MB2, can be found even in the primary ones. In the mandibular, again, the outline of the access cavity is dictated by the number of canals. It is usually trapezoidal, concentrated more on the mesial aspect, and there can be 3 to 4 canals. The 4 canals are more commonly found in this mandibular molar. The 4 canals being mesobuccal, distobuccal, and mesolingual and distolingual canals. The common errors in the access opening during the primary teeth are inadequate access, which compromises instrumentation and prevents good obturation; overzealous tooth removal resulting in the mutilation of the coronal tooth structure and weakening, leading to canal orifice, as you can see in this picture; inadequate caries removal resulting in the future caries destruction and discoloration of the crown; labial perforation usually occurs when the angulation of the tooth is not taken into account. There could be focal perforation of any magnitude, which is difficult to repair, causes periodontal destruction, and can weaken the tooth structure. This can be avoided by assessing the depth of the pulp chamber from the preoperative X-ray. Poor access placement and inadequate extension, which can leave orifices unexposed, and thus missed canals could be there. Better extension but not including the fourth canal orifice is also one common mistake. Overextension can lead to unnecessary removal of the sound tooth structure, thus weakening the final restoration. Next step is the working length determination. The working length is the distance from the coronal reference point to a point at which the canal preparation and obturation should terminate. Here there are certain terms which we should be aware of: anatomical apex, radiographic apex, and apical foramen. Anatomical apex is a tip or the end of the root determined morphologically, whereas the radiographic apex is a tip or the end of the root determined radiographically. And apical foramen is the main apical opening of the root canal. It is not necessary that the anatomical apex and the radiographic apex coincide with the apical foramen. The apical foramen can be often located laterally. There are basically two methods of determining the working length. One is radiographic, another is non-radiographic. Radiographic includes the digital radiographs and Ingle and Grossman's methods. Non-radiographical methods are tactile sensation, apical periodontal sensitivity, paper point measurement, and apex locators. Apex locators are not very reliable in primary because of their apical root resorptions. First of all, the most commonly used method is the Ingalls radiographic method. In this method, to establish the length of the tooth with a K file, an instrument stop is required, that is, the reference point is established. Now, the first exploring instrument should be small enough to negotiate the total length of the canal, but not small enough to be loosely fitting. The reference point should be constant, and if the reference point is not constant, then the tooth should be ground or instrumented in such a way that there is a constant and reproducible reference point. It is advisable to estimate the canal length from preoperative radiograph, and this is the length that will be serving as an index. 1 mm is reduced from this length so as to allow for any magnification or image distortion. Then after that, this predetermined length, the stop is adjusted and the second radiograph is exposed with this file in place, and now the difference between the end of the instrument and end of the root canal is noticed. This difference is adjusted and the safety factor of 0.5 to 1 mm is deducted to confirm the apical termination at the apical constriction and not the apical foramen. Wien recommended certain modifications based on root or bone resorptions present. He recommended that if there is no root or bone resorption, then it should be 1 mm short of the apical foramen. If there is bone resorption, then 1.5 mm it should be shortened. And if there is both root and bone resorption, then it should be shortened by 2 mm. Grossman proposed this formula: radiographic length of the file divided by the actual length is equated by radiographic length of the tooth divided by actual length of the tooth. So that is how the actual length of the tooth is determined. After the working length has been determined, now it is the time to prepare the root canal. Certain considerations in primary teeth which should be kept in mind. First is the multiple ramifications of the root of the radicular pulp. Therefore, complete debridement is next to impossible. Ribbon-shaped canals with narrow mesiodistal width compared to their buccolingual dimensions. This discourages gross enlargement of the canals because it might lead to lateral perforations. In primary teeth, attempts to prepare a circular apical 1/3 may result in lateral perforation because of its hourglass shaped morphology. And filing is done only to remove the pulp tissue and not to enlarge. Therefore, the term pulpectomy and not root canal treatment for primary teeth. H file number 15 or 20 is strongly recommended as they remove hard tissue only on withdrawal, and this prevents pushing of the infected material through the apices. Kennedy suggested that the maximum size to be used in primary root canals is 30, and each canal should be enlarged 3 to 4 times the instrument sizes greater than the first file. Matheson suggested 15 to 35 size files only to be used in primary. Motions of the instruments are push and pull motion and reaming motion. Push and pull is the straight back and forth movement. A canal wall can be very quickly damaged by this motion. Reaming is turning clockwise and then anti-clockwise. Turn and pull is slight quarter turn followed by a straight outward pull. And watch winding motion, which is commonly used with H files. And this is the balance force motion, where a quarter turn to the right and then the larger arc used where the file is rotated to the left to drill the canal open. And this is done till the working depth is reached. Another recent advancement in the canal preparation is the pediatric rotary instrumentation. Now, the basic need for these separate pediatric rotary instruments was that the permanence, the files that are used in permanent instrumentation were, first of all, the length is more, and secondly, due to the even taper, the preparation of the root canals is not possible in the primary. So therefore, the thinner curved root canals with ribose-shaped morphology increase the chance of lateral perforation, and the longer file length is difficult to use in the pediatric patients. Therefore, these files, they have an uneven or rather variable taper and shorter lengths. These pediatric rotary instrumentations, they reduce the instrumentation time and improve the quality of obturations. These are the files which are commonly available in the market for pediatric endodontics: ProF baby gold files, Prime Pedo files, and Kido S pediatric rotary file system. Irrigation forms a very integral part of the pulpectomy, reason being it is not possible to instrument or clean the root canals and debride them with the mechanical files, and therefore it is not the mechanical instrumentation which is primary in the dentistry. It is basically chemomechanical debridement, and therefore irrigation is an important part. So let us see what is the need for this irrigation. Microorganisms which are remaining in the root canal space after the endodontic treatment or recolonize, they are the causes of main endodontic failures. And the root canals in the primary teeth, they consist of ribbons, lateral canals, and multiple ramifications. So instruments cannot reach there. The ideal requirements of irrigants are they should have a broad antimicrobial spectrum and should be efficacious against the anaerobic and the facultative microorganisms, should dissolve the pulp tissue and organic debris, should inactivate the endotoxins, they should be good lubricants and remove the smear layer, and they should be non-toxic, non-caustic. So therefore, an ideal irrigation is a combination of multiple irrigants. This was the irrigation protocol given by Kandasamy et al. In 2010. The primary irrigant has been proposed to be sodium hypochlorite during the instrumentation. It should be used copiously after each instrument to flush out the debris. EDTA or citric acid should be used after shaping for 1 minute using 5 to 10 ml of the solution, and the final rinse should be done with chlorhexidine, which is antibacterial and has a property of substantivity. The irrigation technique. The needle should be thin enough to reach the apical regions of the root canal, and the solution is not injected more than 1 mm of the needle penetration depth. So bulky needles, they prevent the irrigation. So 27 to 30 gauge needles should be used, and preferably side vented needles should be used so as to prevent the apical extrusion of the debris during irrigation. The needle should be free and should not bind to the canal. If it is there, then it should be withdrawn and then irrigated again. Summarizing the irrigation and the various authors, let us see with the various authors who proposed the primary irrigating solutions in the destrous teeth. Mathewson proposed sodium hypochlorite, Kennedy again sodium hypochlorite, Stewart and Barber, they proposed peroxide and a mixture of peroxide and hypochlorite. Cohen also suggested sodium hypochlorite with EDTA. Stephen V proposed all the three to be used simultaneously. Braham and Morris proposed sodium hypochlorite. Pinkham proposed sodium hypochlorite and sterile solutions. Thank you so much. In the next topics, we'll be covering the rest of the pulpectomy. Thank you.